Welcome back, fellow mitochondriacs, for another episode of Cancer as a Mitochondrial Metabolic Disease. I'm excited to be back with you today to talk about further kind of going into a deeper dive into other hexokinase 2 inhibitors, in particular 2DG. But based off some comments that we had in the last video, I wanted to go a little bit deeper into some of the other ones that we did not talk about kind of in more detail, but I did, cover because they were on the slide that was kind of like the Gestalt slide. So just to reorient ourselves, where we're talking about here, we're talking about the rate limiting step in glycolysis right after glucose is brought into the cell. It has to be converted into glucose 6 phosphate via an enzyme called hexokinase. And this is the enzyme that we spent the last hour talking about, and which we'll be talking about today. And initially, I was going to only talk about 2-deoxyglucose, if I can find the right slide, 2-deoxyglucose. But because of some comments, I wanted to at least give a little bit of time to speak to both melatonin and membendazole and fenbendazole and where they potentially have effects in this arena. So the first one I'd like to talk about is melatonin. And I pulled some papers that I thought were pretty interesting to our story here. So, we talked about melatonin pretty much at length in the past, and we looked at all the amazing things that melatonin can do, whether it be improving the amount, number, and function of mitochondria through mitochondrial biogenesis, or through the recycling of kind of old damaged cellular components called autophagy, or even mitochondrial specific autophagy, where we're getting rid of damaged mitochondria to help hopefully replace them with new ones. We've talked about the wonderful antioxidant effects that melatonin has. We've talked about how it and when it's released and under what circumstances. And we've also talked about its effects on blood glucose. But what we have not talked about in particular is its role in the kind of the regulation of glycolysis in particular, and its role potentially in affecting hexokinase. So this paper was published in April of 2021. It's titled "Melatonin Targets Metabolism in Head and Neck Cancer Cells by Regulating Mitochondrial Structure and Function." And it says here that our results demonstrate that melatonin induces a shift to an aerobic mitochondrial metabolism that is associated with changes in mitochondrial morphology, function, fusion and fission, and head and neck, looks like squamous cell carcinoma. We found that melatonin increases oxidative phosphorylation and inhibits glycolysis, resulting in increased ROS production, apoptosis, mitophagy, and decreased cell proliferation. So I think that I almost always, when I hear these kind of mechanistic studies on how a particular substance functions to improve cancer killing, and the way it does it is that it actually increases oxidative phosphorylation. And I think that it is somewhat confusing for a lot of people if they're hearing this for the first, second, or third time, because essentially the argument that I've been making, that Doug Wallace has been making, that Dr. Seyfried's been making, others have been making, is that the mitochondria in cancer cells are either partially or completely damaged to the point where it cannot make any energy. And the way that Dr. Seyfried talks about this being the case is he'll pull electron micrograph studies of mitochondria that are outside, and not in cancer cells, normal cells, and then ones that are in cancer cells. And, the structure equals function for biological systems. And so when you have kind of empty, vacuolated as he calls, ghost mitochondria without the cristae and the mitochondrial supercomplex formations that are able to be formed because there's no cristae or very few disorganized cristae, then that mitochondria is not going to make very much energy, and it's going to leak a lot of reactive oxygen species. And my belief, as of current belief, is that the reason why hypoxia-inducible factors essentially shut down or remove excess mitochondria from the system is because of that very fact. When you put basically gasoline through a broken engine, it's going to produce a lot of black smoke. And the black smoke is the reactive oxygen or reactive nitrogen species or the oxidative stress. So when you shut that process down, you effectively shut down a major way that a cell in general can kill itself or have apoptosis. So when it's saying here that melatonin increases oxidative phosphorylation, inhibits glycolysis or the Warburg effect, resulting in increased ROS production or reactive oxygen species, which then allows for apoptosis and mitophagy and decreased cellular proliferation. That shows that it's kind of like reinstating the mechanism to self-suicide by increasing basically energy flux through a mitochondria that's broken. And so when you have excess reactive oxygen species that are put off by these broken mitochondria, that will kind of terminally damage the mitochondria that was kind of like hanging on, but not setting it over the edge to create cell suicide, which is what the cancer cell does not want to have. So when we change things, by one of the ways that melatonin we've talked about in the past is it inhibits pyruvate dehydrogenase kinase, and it allows flux of energy to go through the mitochondria that's broken. And that's likely how the ROS increases. We've also seen in other papers that suggest that just by blocking hexokinase, that will lead to redox imbalance by the lack of production of certain things that are able to be made to help protect the cancer cell against oxidative stress. So there's probably multiple mechanisms here, but I just want to highlight that because it's somewhat confusing for folks. And I think it warrants going over the proposed mechanism of how increasing OXPHOS within a cancer cell actually kills it. I just wanted to touch on that. Our findings highlight new molecular pathways involved in melatonin's oncostatic activity, suggesting that it could act as an adjuvant agent in a potential therapy for cancer patients. We also found that high doses of melatonin, such as those used in this study, for its cytostatic or cytotoxic impact on these head and neck squamous cell carcinoma cells, might lead to additional effects through melatonin receptors. And then later on in the paper, it says that with regard to the effect of melatonin treatment on head and neck squamous cell carcinoma and glycolysis, hexokinase 2 levels, protein levels, were determined. At 500 micromole, melatonin significantly decreased hexokinase protein content in these cancer cells after only 5 days of treatment. So I wanted to highlight that because you're gonna see there are at least two mechanisms of how melatonin affects hexokinase. Number one, it works through a variety of molecular mechanisms to actually decrease the amount of hexokinase available or decrease its expression. That's number one. And we'll also see there's another mechanism as I go through these. The next paper I wanted to talk about was one that was published in September of 2022, and it's titled Melatonin Inhibits Glycolysis and Hepatocellular Carcinoma or Liver Cancer by Downregulating Mitochondrial Respiration and mTOR basically activity. And it says we analyzed the time-dependent effects of melatonin on mitochondrial respiration and glycolysis in liver cancer cells. The results showed that from a cell bioenergetic point of view, melatonin caused an acute reduction in mitochondrial respiration. However, increased reactive oxygen species, therefore inhibiting mTOR activity from an early stage post-treatment without affecting glycolysis. Nevertheless, administration of melatonin for a longer time reduced expression of the c-Myc protein, therefore suppressing glycolysis via downregulation of hexokinase 2 and lactate dehydrogenase A, or LDHA. The data presented herein suggests that melatonin suppresses mitochondrial respiration and glycolysis simultaneously in hepatocellular carcinoma cells, leading to anti-cancer effects. Thus, melatonin can be used in an adjuvant as an adjuvant agent for therapy for liver cancer. Again, knowing what we know at this point about aerobic glycolysis, about the sugar addiction of cancer, about the Warburg effect and how it's a hallmark of cancer in general. Obviously, these folks are specifically saying it could be an adjuvant chemotherapy or an adjuvant therapy in the last publication for head and neck cancer. And this publication, they say it's a different group, but they say basically that melatonin can be used as an adjuvant for liver cancer. And I think they kind of like, I don't know if they have to say that because they're only studying liver cancer cells. And they're not really looking at cancer as a whole, as a metabolic disease. But I think that based off of what we know, we can say that likely it's going to be a universal situation, given that aerobic glycolysis Warburg effect is a hallmark of all cancer. I just wanted to touch on this a little bit. So number one, melatonin will actually enhance energy flux through this mitochondria. And that energy flux will create massive amounts of reactive oxygen species, which is going to have an effect on mTOR and subsequently c-Myc. And then that's going to have downstream effects on lowering the amount and availability of hexokinase 2, which we're talking about in this particular kind of micro series. But then it's also going to have effects on lactate dehydrogenase A, which will come back later when we talk about lactate dehydrogenase A, when we have a whole video about LDH. And then that'll, of course, shut down glycolysis and the lactic acidosis. It's going to help in multiple ways. And then that will ultimately lead to decreased cell proliferation. And you could also make the argument that it's also going to lead to decreased cellular antioxidant availability and response, so that this ROS can actually do what it's trying to do, which is cause cell suicide. The next paper was published in January of 2024, and it's titled "Melatonin, a Modulator in Metabolic Rewiring in T-Cell Malignancies." And I pulled this paper for a couple different reasons. Because number one, I think that a lot of people, not a lot of people, but there are people who, will watch the videos and will be going through the literature, and they'll be wondering, does this work on, ALL or CLL or whatnot? And I like to publish or, put up papers that have to do with, non-solid tumor, like these T-cell malignancies, to show that the same process that is happening within, a solid tumor like a breast cancer or a glioblastoma multiforme is happening at some level on, these other cancers as well. And it says here, further, melatonin plays a modulatory role in the expression of the essential transporters GLUT1 and GLUT2. I went ahead, because of this paper, I updated my list. I did not see that it had an effect on GLUT2. I only saw it have an effect on GLUT1. So I updated this list of GLUT inhibitors to show that it has a GLUT2 downregulation or inhibition as well. And then it's also, which was responsible for nutrient uptake and metabolic rewiring, such as glucose and amino acid transporters in T cells. And so this paper just goes on to show that, melatonin is having effects, multiple effects. A lot of these, nutraceuticals that come from plant sources, or, endogenous hormones like melatonin and its derivatives, we're going to look at it in each video at a very specific way that it helps us, right? But a lot of these compounds, such as melatonin, they have diverse effects. Okay. Like just as an example, we can see here that melatonin is working to, regulate macrophages and T cells, but also inflammation through NF-kappa B, hypoxia factors, regulating glycolysis at multiple levels, and a lot of the gene expression that also is being upregulated, such as c-Myc and HIF and others. So we'll come back to melatonin over and over again as we kind of like pick apart its variety of cellular mechanisms and how it helps us, in the war, kind of against cancer. But I just wanted to particularly show that it has multiple effects on glycolysis, not just hexokinase. It has the GLUT1 and GLUT2, but it also is active and helping even in non-solid cancers such as myelodysplastic syndromes and T cell malignancies. And then the last thing I wanted to cover with melatonin was the fact that it doesn't just downregulate hexokinase, it actually inhibits it as well. And it says here that that melatonin has been proven to suppress the action of hexokinase by binding to the enzyme directly, modifying its structure and activity. This interaction stops hexokinase from phosphorylating glucose to make glucose to glucose 6-phosphate. That's what hexokinase does, and inhibiting glycolysis efficiently. Because glucose trapping is reduced and glycolysis cannot continue as normal, leading to decrease in glycolysis and hence energy supply to malignant cell declines. So not only does it have, effects at, blocking inflammation and hypoxia factors and c-Myc and mTOR and all these other ones that are like all these pathways that are kind of like upregulating hexokinase expression in the nucleus that makes it abundant. It also, in addition to that, will actually directly block hexokinase by inhibiting it, by modifying its structure and activity. And I thought that was an interesting kind of like finding. I think a lot of times, when we talk about these hexokinase inhibitors, it would make the series way longer if we looked at, how exactly EGCG or sulforaphane or artemisinin blocks a specific pathway. And it may be kind of an indirect way through molecular machinery and chemical pathways or biochemical pathways. And sometimes it is a direct inhibition. And it's hard to really know sometimes it's not obvious. They just know that it does it. And so, wherever I can, I'll try to, make that distinction, whether or not it's a true inhibitor or if it's a just down-regulating expression of a certain, transporter or in this case, an enzyme such as hexokinase. So the purpose of this video initially was going to be to talk about 2-deoxyglucose because I think it's a very kind of exciting topic. I think that there is a ton of promise with 2-deoxyglucose, but it is a sadly understudied agent. And what I mean by that is that research has studied it for a long time. I think I was able to find papers as early as like the early 2000s on 2-deoxyglucose. And there are papers that you'll see here that it's studied all the way up until now. I see some issues with the way that it's been studied, and there have been, unfortunately, I would guess, very little interest from industry to publish human clinical trials because that is what is this part that's sadly missing. There's kind of a lot of preclinical and mechanistic studies of how 2-deoxyglucose works and its effectiveness. It's just that when it comes to human trials, we are sadly missing those. So let's start by kind of reading some of this abstract. It was published in December of 2014 and it's titled 2-deoxyglucose, 2-deoxy-D-glucose, targeting of glucose metabolism in cancer cells as a potential therapy. And it says here that 2-deoxy-D-glucose, 2DG, a glucose analog, targets glucose metabolism to deplete cancer cells of energy. In addition, 2DG increases oxidative stress, inhibits this N-linked glycosylation, and induces autophagy. It can efficiently slow cell growth and potentially facilitate apoptosis in specific cancer cells. So I'm liking what I'm hearing so far. And just to kind of look at, at least according to this paper, the proposed mechanism is that it's kind of a negative vicious cycle in a good way, because you can see here that the 2-deoxyglucose kind of parent molecule is blocking GLUT transporters or inhibiting GLUT transporters. Then when 2-deoxyglucose gets metabolized like normal glucose would by hexokinase, it turns into 2DG6-phosphate instead of just glucose 6-phosphate. And then it has inhibitory effects on hexokinase and this other PGI enzyme. So my point is that it has multiple effects. And then because of further chemical modification, it will then lead to other areas where it blocks. So my point is kind of like a vicious cycle in a good way for these cancer cells as it becomes metabolized and kind of further activated. A lot of times when certain molecules are metabolized, they become inactive or, they lose their effect. But in this case, that doesn't seem to be the case. The next paper I wanted to talk about was published in December of 2019. It says 2-deoxyglucose, 2-deoxy-D-glucose, and its analogs from diagnostic to therapeutic agents. And I pulled quite a bit from this paper because it was pretty good. So the ability of 2-deoxy-2-D-glucose, 2-deoxy-D-glucose, 2DG, to interfere with D-glucose metabolism demonstrates that nutrient and energy deprivation is an efficient tool to suppress cancer cell growth and survival. Acting as a D-glucose mimic, 2DG inhibits glycolysis due to formation of intracellular accumulation of this 2-deoxy-D-glucose 6-phosphate, 2DG6P, inhibiting the function of hexokinase, the enzyme we've been talking about, and glucose 6-phosphate isomerase, and inducing cell death. In addition to glycolysis inhibition, other molecular processes are also affected by 2DG. Attempts to improve 2DG's drug-like properties, its role as a potential adjuvant for other chemotherapeutics, and novel 2DG analogs as promising new anti-cancer agents are discussed in this review. And so the first thing I wanted to talk about was just kind of like, what is 2DG? And what I can say is that this is a normal, what we call D-glucose molecule. And what you're seeing here is, carbons where there's not an O, but where you see an angle here is representing a carbon. And what you're seeing here is that at this position, at the 2 position, you're seeing a hydrogen proton, and you're seeing an OH molecule. We call that an alcohol. And what's happening is that the alcohol is being removed and replaced with a proton. So the molecules look very similar, but even just that is enough of a change to fool that hexokinase molecule to actually, first of all, it's going to take this and phosphorylate it and make it into that G6, instead of G6P, this 2DG6PD. And that causes further, kind of like mucking up of the works. And then it also, will block it directly. So the first graphic that this paper had, I thought was interesting. So it's saying that in normal tissue, oxygen and glucose get into the cell. Glucose will be transformed to pyruvate via glycolysis, and then enter into the TCA cycle and go through oxidative phosphorylation, make large amounts of ATP, and very without oxygen, glucose will go and make lactate at a very, inefficient way. But that's under anaerobic conditions, like if you're drowning or if you're doing like crazy, sprints and high intensity interval training. But this is like a very, limited amount because you can't sprint forever, right? You'll at one point stop and you'll go back to oxidative phosphorylation in order to survive and get back to normal metabolism. However, in a tumor cell, we're making, a lot of lactate, more than 85% or even higher, depending on the amount of damage in that particular mitochondrial system or colonies. But my point is that the majority of it goes through pyruvate to make lactate. There's an enzyme between pyruvate and lactate called LDH, and the majority of glucose, the massive amount of glucose is being made, is going to be to make lactate, and the fermentation of glucose to make lactate, and that lactate is going to set up shop outside the cell and create, the tumor microenvironment, et cetera, et cetera. This is again the Warburg metabolism. So this paper is just kind of showing the difference, as if us, the audience, were unaware of these two different metabolic routes. And so what's happening here is that when glucose is being upregulated by these Warburg dependent and glucose dependent cells, it's making, like we've talked about this in the past, but through the PPP, it's making nucleotides. It's also making what's not shown here, NADPH, which is very important for antioxidant systems. It's making other, nucleotides and amino acids. One of the things that Dr. Seyfried's slide that's kind of similar to this showed was it's making glycine. Glycine is one of the 3 amino acids that make up, glutathione. So it's not just making energy and making lactate and making, ATP through through this Warburg effect. It's also, making all the biomolecules needed for rapid cell growth and et cetera, and antioxidant systems, et cetera. And again, very small amounts are getting into the mitochondria because, number one, the mitochondria are inhibited by hypoxia factors, both at complex 1 and through excess mitophagy, but also through the upregulation of the PDK enzyme, or the pyruvate dehydrogenase kinase enzyme, which blocks this from happening. So that's why there's such a small amount of pyruvate getting to the mitochondria. And it's that blockade of pyruvate getting to the mitochondria that actually allows the damaged mitochondria to kind of like hang out and not cause apoptosis. When we give things like melatonin and we actually uninhibit this process and we allow pyruvate to get into this broken mitochondria, that's when oxidative phosphorylation can kind of restart. Because the process is broken, that's when the restoration of apoptosis is allowed to happen. But I'll digress. So what it's showing here is that in this paper is that 2-deoxyglucose gets into the cell just like normal glucose would through these glucose transporters, these glutes, right? And then it gets converted via hexokinase to 2-deoxy-D-glucose 6-phosphate, which basically further like inhibits hexokinase as well as other enzymes. And then it basically stops glycolysis in its tracks, leads to ATP depletion and ultimately cell death. And, this is if it's not inhibited, right? This is if glucose is allowed to enter the cell, the Warburg metabolism continues, ATP and anabolic state is enhanced, or is intact, I should say, and the cells are able to proliferate. What 2-deoxyglucose is stopping this side of it, right? You have glutamine in here too. It's not really, talked about much in this paper. But my point is that as I think that one of the big reasons why, metformin or many of these substances that are studied in a vacuum don't have the clinical outcomes that we would be hoping for, is because it's studied in a vacuum. And you can't just shut down glycolysis, although glycolysis is critically important. You can't just shut down glycolysis to have the effect you're looking for. Will this help? Yes. But will you have like profound, like, kind of disease reversal or things like that just by blocking glycolysis? Probably not. That's why the ketogenic diet, low glucose intake, et cetera, is the foundation, but it's not the total treatment, right, for metabolic therapy. Moving on. So this paper was even more recent than the last. It was titled multifaceted, entrancing role of glucose and its analog 2-deoxy-D-glucose in cancer cell proliferation, inflammation, and virus infection. And this, I'll be very frank, this to some degree gets us off topic a little bit, but it just shows, I wanted to show a little bit of the diversity of where 2-deoxy-glucose could be, showing benefit. And this paper does a really excellent job of doing that. So what it says here is that chronic exposure to high glucose inside the human body helps the progression of cancer by activating various signaling pathways, including PIK3, AKT, mTOR, RAS, RAF, MAPK, PKC, etc. Hyperglycemia induces reactive oxygen species and AGE, or advanced glycation end products, production, and decreases the functional activities of cellular antioxidant systems. By downregulating the prolyl hydroxylase, it stabilizes HIF-alpha. So just hyperglycemia is a cause of pseudohypoxia, which downregulates this prolyl hydroxylase, which stabilizes hypoxia factor, which leads to the entirety of the Warburg effect and enhanced glutaminolysis, leading to EMT-induced cancer progression and inhibition of apoptosis. How does it do that? It shuts down mitochondrial flux of energy, basically, through PDK. High glucose level increases inflammation by creating a pro-inflammatory environment through the production of certain pro-inflammatory mediators, cytokines, chemokines, leukotrienes, and by influencing the recruitment of immune cells, leukocytes, in the inflamed region. I didn't highlight all of it because it would just get monotonous. 2-DG is a modified form of D-glucose that shows anti-cancer, anti-inflammatory, and antiviral effects. It enters into cells through GLUT transporters and is converted to 2-deoxy-D-glucose 6-phosphate with the help of hexokinase. It inhibits the glycolysis, the TCA cycle, the pentose phosphate pathway, leading to ATP depletion. By downregulating glucose uptake and energy ATP production, it halts various pathways responsible for cancer progression. It promotes the formation of anti-inflammatory mediators and macrophage polarization and modulates immune function, which decreases inflammation. So as you can see here, even though 2-DG is just a hexokinase inhibitor, it has profound diverse effects that I think are worth mentioning. So when it comes to hyperglycemia and inflammation, it says here that inflammation is a form of the body's immune response against certain pathogens, toxic particles, and harmful stimuli. It is marked by swelling, heat, pain, redness. We call that calor, dolor, rubor, and I can't remember what the Latin for loss of function is, but that's like a classic way of in medicine of describing inflammation. An increase in release of pro-inflammatory cytokines, chemokines, and immune cell recruitment is found in hyperglycemic conditions. So just, being hyperglycemic or being diabetic will increase your inflammatory state, which is at least partially how it leads to downstream damage, of your heart, your lungs, of your eyes, of your kidneys, etc., which promotes inflammation. Also, high glucose activates endothelial cells, generates oxidative stress, downregulates nitric oxide, and enhances advanced glycation end product formation. A study indicates the hyperglycemia has a regulatory effect on IL-6, which is a pro-inflammatory cytokine, and lactate dehydrogenase expression, and plays a synergistic role at inducing inflammatory and hyperimmune responses in COVID-19 patients. Alzheimer's disease is a neurodegenerative disorder characterized by a loss of brain function. A high blood glucose may compromises the blood-brain barrier integrity, as well as increases the production of inflammatory molecules like TNF, tumor necrosis factor alpha, and MMP, matrix metalloproteinase 9, that promote neuroinflammation. You can see that this problem with hyperglycemia and inflammation, oxidative stress is wide-reaching through a variety of pathologies, not just cancer. And then it says figure 2, which is the next figure that I'm going to show you. of hyperglycemia and inflammation. High glucose activates endothelial cells, generates oxidative stress, downregulates or deregulates nitric oxide and age formation. The elevated TNF alpha binds to the TNF receptor and expression of all these other molecules, these ICAM, VCAM, ELAM, increases the endothelial cells through the NF-kappa B pathway, which is a major inflammatory pathway. Overproduction of NADPH in hyperglycemia increases toll-like receptor 4 expression on monocytes through the activation of PKC. Chronic hyperglycemia overexpresses these damage-associated molecular pathogens, or DAMPs, which bind to PRR, enhances production of basically what it's saying is it's a vicious cycle. I mean, that's what it's saying without saying it, right? So hyperglycemia turns on like the entirety of inflammation, through more innate pathways, the DAMPs and the PAMPs, and then, kind of more adaptive through, inflammatory cytokines and T cells and et cetera. So my point is that hyperglycemia is responsible for upregulation of inflammation. Inflammation generally is bad for everything, including cancer, but it also upregulates oxidative stress, as well as increasing stability of the hypoxia-inducible factor, HIF1, which is a vicious cycle with itself, because inflammation will actually increase hypoxia-inducible factor 1 alpha stabilization. And we know the importance of hypoxia-inducible factor 1 alpha within cancer, and in particular in the Warburg metabolism that's set up via its stabilization. It later says hyperglycemia and cancer. Hyperglycemia, hyperinsulinemia, and insulin resistance influence proliferation, migration, invasion, angiogenesis, and apoptosis response in cancer cells, rendering them resistant to chemotherapeutic treatment. In general, hyperglycemic patients become more susceptible to different cancers, including pancreatic, stomach or gastric, endometrial, breast, and cervical cancers. It is evident that type 2 diabetes significantly contributes to thyroid cancer, and researchers discovered that adding metformin to the anti-cancer drug enhanced its efficacy in treating diabetes-induced cancer. In another study, I don't think I can pronounce that without stuttering over it 10 times, but this carcinogen was fed to a hamster model combined with a high glucose diet, showed an accelerated in the carcinogenesis process. So basically what they did was they gave this hamster, poor hamster, gave him a bunch of carcinogens, whatever this is, and then fed him a high glucose diet, and accelerated the cancer creation process, or the carcinogenesis process. And then I'm actually not going to read this. This is just another way of showing how basically hyperglycemia progresses, cancer. And I think it's pretty apparent at this point. But I think the best way to do it is probably show this picture, which is what this, this figure one, explanation is actually kind of just trying to describe this very, very, very busy slide here. But I think it's fairly apparent to us at this point that since cancer is a metabolic disease and it requires massive amounts of glucose, that hyperglycemia would obviously lead to cancer progression. It's just that these researchers wanted to show exactly, all the different variety of mechanisms in which hyperglycemia makes things worse for cancer patients and leads to its progression. So finally, we get to this slide here, which is 2-deoxyglucose and cancer. A vital feature of cancer cell is the Warburg effect. 60% of the ATP inside of a cancer cell is derived by glycolysis. Maybe. I've seen upwards of actually 80, 85, 90%, but I'll digress. I'm not going to correct the author. It is only providing it not only provides macromolecule precursors for rapid proliferation, but it also creates a suitable environment for cancer cells, aka the lactic acid tumor microenvironment. 2DG is a potential anti-cancer drug. In cancer, 2DG works as an anti-proliferative, anti-angiogenic, and anti-metastatic drug. and also reduces cancer cells' chemotherapeutic drug resistance capacity. After entering the cancer cell, 2DG is converted to 2-deoxy D-glucose-6-phosphate by the enzyme hexokinase, the enzyme that we've been talking about, which acts as an inhibitor of the glycolytic pathways. It intercepts glycolysis by decreasing hexokinase and phosphoglucose isomerase activity. There are 4 isoenzymes or variants of hexokinase that are present in mammals. Among them, hexokinase 1 is expressed in the human body. Hexokinase 1 not only helps the glycolysis process, but also in cancer progression by upregulating the MAPK, ERK pathway and promoting cancer cell proliferation, invasion, metastases in the lung, breast, colorectal, and pancreas. 2DG inhibits hexokinase function through competitive and allosteric inhibition and decreased lactate production and ATP synthesis in glycolysis. It has also been found that this monoclonal antibody, crizotinib, I'm sure I'm butchering that, crizotinib, in combination with 2DG, synergistically inhibits HK-mediated cancer invasion, colony formation, and proliferation through the inhibition of the PIK3, AKT, mTOR signaling pathway. Thus, due to the lack of ATP, the PIK3, AKT, mTOR pathway is halted, leading to a decrease in proliferative proteins. Buforin 2B is a well-known antimicrobial peptide that shows an effective anti-cancer effect. And a recent study found that the combination of this buforin 2B and 2DG inhibits cancer cell proliferation rapidly through the decrease of ATP and lactate production. It later says that, so this is basically just explaining this figure, which we've kind of touched on when we read that paper. So 2DG is going to increase ROS and lead to apoptosis, hopefully. It's going to lead to a decrease in anti-apoptotic proteins, and it's going to increase pro-apoptotic proteins. It activates multiple cellular mechanisms to enhance apoptosis, not only through these pro-apoptotic proteins, but also through the caspases, which is part of how other things like melatonin and dichloroacetate, et cetera, work. And then it's going to have effects on inflammation, like we talked about it in previous slides, which also drives, cancer and metastases. But it's kind of like most well-known way of affecting cancer is through this hexokinase inhibition, because once it gets metabolized to this glucose-6-phosphate, or I should say 2DG6-phosphate, it will have an inhibitory effect on hexokinase. And then through other molecular mechanisms, through inflammation and through other kind of like mTOR pathways, et cetera, it will also downregulate hexokinase, so it's not even available for being used. Let me take a look at some of the comments. Wow, I've actually missed a ton of comments, so I apologize for that. I was kind of on a roll there, but I wanted to really get into the nitty-gritty of how 2-deoxyglucose works, and why it works, how it works, but probably why it has not panned out, as we'll see. As first of all, it needs to be studied more, number one. But number two, it's not panned out as a mono agent, as no thing probably will, right? I mean, unless the agent literally does, glucose and glutamine and, increases reactive oxygen species, it's kind of like a metabolic therapy in a bottle. It's not going to likely work as a mono agent. So therefore, it's likely, when they criticize it at not, working as a mono agent, I think that's like to be expected. But anyway, I'll digress. So it looks like Michael's on a 4-day water fast. Told I must get radiation and chemo. Surgery is not recommended. The position. Probably. Your GKI is 0.56. That's unbelievable. Good, man. That's really good. Oh, I'm sorry about the teeth removal. That's horrible. Trying to find the doses for things like EGCG, turmeric, berberine, melatonin. Any help on the comments would be appreciated. Well, I want to help you, Michael, but I don't give dosages and kind of clinical medical advice like over YouTube. It's not the role of the channel, and it's not really an ethical thing to do over, and a good thing to do as a doctor. The information is out there, in terms of like dosing and strategies. And I think this just is a gestalt answer that I give most people when they ask me about dosing is I say, hey, find a local, ideally, integrative doctor who has a clue about these things and have them help you through this. That's the best. I don't also was told what my timeline would be if I don't do the standard of care. Well, I will tell you this, Michael, nobody is God except for God. So they don't know the timeline. They can give you their best guess, based off of their, opinion and their experience, but no one can tell you how long you're going to be here on the earth. I have found Chat GPT quite helpful for dosing. You need to ask something like, what dosages were found? Thank you, Jesse, for that. I'd also like to maybe fact check Chat GPT just to see where they're getting that information from. But I think that's not a bad idea. Obviously, I think asking an integrative doctor would be better, but they're few and far between who know about metabolic therapy. Okay, glycine tons in collagen. Mark says, yeah, I don't know what you mean by that, Mark. I can tell you that collagen is made up of generally 3 amino acids, glycine being one of them. So every third amino acid should be glycine. So there's a ton of glycine in collagen, I'm guessing. So I'm guessing what you meant by that. Maybe just check out. Oh, okay, he's given advice to Michael there. All right, a lot of good chatter between you folks. I'm glad there's a willingness to help each other. I think that's how we're going to get through this. Is we're going to, we're all going to use our experience, and we're going to, and our knowledge that we've learned, and we're going to share it with each other, and we're going to demand change so that we can have this be the standard of care and not what the standard of care currently is. So moving on. So I just thought this was an interesting slide that I got from this paper. Again, the same paper that was, let's see here, when was this published? This is a pretty recent paper, 2022, right? This paper was pretty interesting. I'm not going to read off every single thing, but it just shows that how D-glucose or normal glucose upregulates and activates all these things, right? And inhibits things that help protect us. So being in a hyperglycemic, state with cancer is kind of like the worst case scenario. So, when you're being fed, ho-hos and bonbons, at the cancer center, that's probably like the worst possible thing that you could be ingesting to give yourself a shot. So at minimum, cut that stuff out because it's going to upregulate and downregulate things that are going to hurt you. And then when we give 2-deoxyglucose, it kind of like reverses course for a lot of different things and down regulates and inhibits a lot of things. So even though, 2-deoxyglucose is best well known as a hexokinase inhibitor, and that's where in general, we will see it being used within cancers and metabolic disease. It doesn't mean that there's not all kinds of other cool things and good things that it's doing to help us improve our situation here. So I wanted to share this because there's some interesting kind of synergistic effects that can be found with 2DG. So in some clinical trials, it was evaluated that the anti-diabetic drug metformin has anti-cancer properties. We've talked about that at length. Cancer cells treated with metformin consist of high fatty acid and low purine nucleotides, which interprets metformin's anti-cancer activity. Cancer has the features of radiotherapy resistance. 2DG upregulates this NAMPT level and NAD positive level, which makes cancer cells radiosensitive. So the first thing is that there is a synergy between 2DG and radiotherapy or radiation therapy. A combination of 2DG metformin further increases the radiosensitivity of cancer cells and significantly arrests the G2M phase of the cancer cells or cell cycle, inhibiting the protein N glycosylation and ER stress induced by 2DG can further be potentiated by metformin, resulting in increased mitochondrial mass, which led to cancer cell detachment from the growth surface. Additionally, 2DG, when added in combination with metformin, was reported to downregulate this program death ligand 1, PDL1 levels, thus inhibiting the immune escape of cancer cells. So basically, like they're saying that it also enhances our own immunity against cancer, has almost having nothing to do with glucose and glutamine. I wonder if maybe that is because the tumor microenvironment is less acidic, and that maybe has an effect on that PDL1 ligand or not. I'm not sure. I have to look into that. Therapy-induced senescence, a common outcome of cancer therapy treatment, and is found to be induced by radiation-induced apoptosis targeted chemotherapy, RIATC. Anti-tumor cytotoxic efficacy of RIATC was found to be enhanced when combined with 2DG or 2-deoxyglucose, as it stimulates the intrinsic apoptosis pathway and sensitizes cancer cells to chemo and radiation treatment. So again, if there's nothing else we can take from a lot of these substances, is that there seems to be not only an enhancement of chemo and radiation, but even an unlocking of either chemo or radio resistance or immunotherapy resistance when you add in these metabolic kind of inhibitors, as we've seen in the past, kind of over and over and over again. So by, if you were to, have a doctor who was able to oversee the use of 2DG and metformin, that is likely going to enhance the standard of care, not make it worse. Conclusion of this paper: prolonged hyperglycemia promotes cancer by increasing proliferating proteins, namely this MMT, EMT, E-cadherin, etc., as well as helps in increasing the chemotherapeutic drug resistance capacity of cancer cells by regulating this TOPO2 alpha. High blood glucose plays a vital role in inflammation by regulating adhesion molecules, immune cells, and TLR's function and releasing pro-inflammatory cytokines. Patients with hyperglycemia are more susceptible to viral infection due to altered immune systems and an increase in viral replication and growth. 2DG is a modified form of D-glucose, which inhibits glycolysis, energy production, and glucose uptake, halts different pathways in cancer progression, alters viral replication, and helps the immune system modulation and reduces inflammation. The only variation in the structure of glucose and 2DG is that the latter has an H at the 2 position instead of an OH group. It is simpler to produce, easy available, and yet a lot more efficient therapeutic agent in managing a wide variety of diseases. I think that's kind of like a little bit of a shot to the gut or the kidney maybe to pharma, like saying, look, this is easy to produce, it's cheap, it's readily available, and it's going to be more effective and efficient at treating a whole host of disease processes. Yet here we are 3 years after this paper was published, and it is not being used at all in the standard of care. The next paper is titled 2-deoxy-D-glucose, a novel pharmacologic agent for killing hypoxic tumor cells, oxygen dependence lowering in COVID-19 and other pharmacologic activities. And, it says the non-metabolizable glucose analog 2-deoxy-D-glucose has been shown in promising pharmacologic activities, including inhibition of cancer cells and in glycosylation. It shows all the different ways that, in 2-deoxy-glucose can affect, cancer cells in particular. It's a really kind of a crappy graphic. You can barely see like what it's saying, but it's basically highlighting all of the things that we've talked about to date. In particular, kind of like this slide is much better highlighted here and easily to read than this, although it's showing very similar things. I pulled this paper because it has a lot of the trials. Okay. So as you can see here, there are, kind of like a bunch of trials. I don't know how many exactly. I'd say like probably 30 if I had to guess, trials on 2-deoxyglucose. And it's a lot of times being used in combination with other things like either metformin or chemotherapy medications, radiotherapy. I'm not sure if I'm seeing any. Okay, here we got some monoclonal antibodies, resveratrol, fenofibrate, ferulic acid. I'm guessing that's like an iron kind of compound with irradiation. Yeah, so mostly chemo, some radiation trials, some metformin trials, and like a couple that are with nutraceuticals. My point by showing this is that if you look now, I'm going to highlight here, what are these? Preclinical, all the way down. Do you see one with docetaxel, and that's a clinical trial? All these are preclinical. Again, docetaxel, clinical. If you look at the references, the same reference. So these are actually the same study. There's really only like one study done. Head and neck cancer, docetaxel, or excuse me, lung cancer, docetaxel, not same reference. It's 9. So there's really been only, that I could find, one true clinical trial done with 2DG, which I think is sad, to say the least. But that's where we're at in 2025. Now, before I go to that trial, I wanted to show this. I thought this was an interesting additional mechanism to how 2DG actually functionally works. So the inhibition, this was published fairly recently, April of 2024. It says inhibition of the thyrodoxin 1 enhances the toxicity of glycolysis inhibitor 2 deoxyglucose by downregulating SLC1A5 expression in colorectal cancer cells. And it was saying that our results demonstrate that a novel adaptive mechanism of glycolytic inhibition, in which this thyrodoxin TRX1 increases glutathione levels by regulating SLC1A5 to rescue cytotoxicity of 2DG in these colorectal cancer cells. Inhibition of glycolysis in combination with inhibition of this TRX1 and or SLC1A5 may be a promising strategy in colorectal cancer cells. So it seems like some of these researchers are like the light bulb is like kind of turning on. I don't know why it's taken so long. Dr. Seyfried's been talking about this for 15 years or longer. The book came out, I think, in like 2013 or 2014. The paper, Cancer's Metabolic Disease, and subsequently the Press Pulse paper came out in 2017. He's been beating the drum for a long time. He's on every podcast known to man. He's everywhere. And yet cancer researchers are not seemingly, the light bulbs aren't seemingly come on, until like the most recent publications. And again, this is like April of 2024. And basically what they're saying in a nutshell is that when we block glucose, there's a paradoxical increase in the thyrodoxin molecule. And thyrodoxin is an antioxidant system that is, it's its own oxidant. It's how do I say this? It's its own antioxidant system. So it can have antioxidant effects by itself. But then on top of that, it will actually upregulate this glutamine transporter, which we've talked about several times in the past, this SLC1A5, which is going to bring in glutamine. It's going to upregulate glutathione production, and then it's going to help shut down ROS. And you can see here that when we block glycolysis, it leads to ROS and it leads to cell death. But because there's like a paradoxical upregulation of this TRX and glutathione production, that kind of shuts that process down to having an effect, which is why you're never going to have a monotherapy effect. It has to be hitting two things at once. You have to hit glucose and you have to hit glutamine at the same time, while increasing ROS to lead to the problem, to the cell death we're looking for and the clinical outcomes we're looking for. And it was just kind of, I think this was kind of like a light bulb moment that this research group had, where they're saying, oh, well, we found that when we block glycolysis, this happened, and glutathione was enhanced and kind of like mitigated this cell death. But when we inhibited both glucose and glutamine, or if we inhibit this TRX1, it also led to cell death. So I just thought that was kind of interesting. The next paper I wanted so this is one of the only clinical trials. I found a couple more. There was, even though this paper only highlighted one, I found a couple more. So the first one that I found was basically this German group in 2005, August, that was trying to enhance basically brain cancer or glioblastoma multiforme sensitivity to radiation therapy. Okay. So what this paper was titled was Optimizing Cancer Radiotherapy with 2-deoxy-D-glucose Escalation Studies in Patients with Glioblastoma Multiforme. And it says higher rates of glucose utilization and glycolysis generally correlate with poor prognosis and several types of malignant tumors. That we know. It later says that 7 weekly fractions of gamma rays, gamma radiation were delivered to tumor volumes. Okay, they basically were given 7 treatments of radiation therapy to the brain, plus to the tumor itself, plus a 3-centimeter margin. So that's pretty wide margins of radiation therapy. And then they gave escalating doses of 2DG, 200, 250, and 300 milligrams per kilogram by body weight, which I'm telling you is huge doses. Very, very big doses. And were administered orally, okay, 30 minutes before they irradiated the patients after an overnight fast. So there's some kind of like method to the madness here. So they had these patients fast the night before up until the time they got the 2DG. Why? Because they're trying to make these cancer cells as hungry for glucose as possible. And then you add something like 2DG at a pretty high dose, and you get them to preferentially uptake this 2DG to then have it have the effect, right? I want to say that this was done orally. It was not given IV. Transient side effects similar to hypoglycemia were observed in most of the patients. I have had experience with some patients and clients who have used 2DG, who even at much lower doses than 200 milligrams per kilogram have similar effects of feeling like they're hypoglycemic. Tolerance and patient compliance to the combined treatment was very good, up to 2DG doses of 250 milligrams per kilogram, which is kind of surprising because that's a very, very high dose. And I suspect these patients were not on a ketogenic diet or fat adapted, which a lot of the patients who I've had in contact with who've been on 2DG for a period of time were fat adapted. However, at the higher dose of 300 milligrams per kilogram, 2 of the 6 patients were very restless and could not complete treatment, though significant changes in the vital parameters were not observed even at that dose. So the point that I think that I would like to try to make with this particular publication is that, number one, it's safe even in levels that are very high in patients that are very unlikely to be keto adapted, number one. Yes, you will potentially feel hypoglycemic because of what it does. But according to this study, no one had any real bad outcomes other than feeling like crap, probably, if you're feeling restless and hypoglycemic and probably diaphoretic and who knows what else. They were being given massive doses of 300 milligrams per kilogram. So no significant damage to the normal brain tissue was observed following in the follow-up of 7 out of 10 patients who received the complete treatment and survived, because 2 people dropped out of the treatment because of the hypoglycemia. And those who received the complete treatment survived between 11 and 46 months after treatment, which is, I think 46 months would be pretty long for someone who have a GBM. So this is an old paper. It's published in 2005. I try to get the actual paper. It's in German. I don't speak German. If somebody speaks German and wants to translate it for me and or maybe give me access to the full publication, I can maybe pick this apart a little bit further. Ultimately, the conclusion was that oral administration of 2DG combined with large fractions of radiation is safe and could be tolerated in glioblastoma patients without any acute toxicity or late radiation damage to the normal brain. So I thought this was the first clinical trial that I could find that I believe the same group, let me double check. Yes, the same group, or maybe several of the same authors, published this paper a couple of years later in 2009, September, Clinical Studies for Improving Radiotherapy with 2-deoxy-D-glucose patient status and future prospects. And it says here that phase 1 and 2 clinical trials have unequivocally demonstrated that the combination of 2DG, 200 to 300 milligrams per kilogram orally after an overnight fast, 20 minutes before radiation with large weekly fractions of low LET radiotherapy is well tolerated without any acute toxicity or late radiation damage to normal brain tissue. Non-serious transient side effects similar to hypoglycemia, just to highlight that, induced disturbances like restlessness, nausea, and vomiting were observed at 2DG levels used. Data from these trials involving more than 100 patients have clearly indicated that a moderate increase in survival with a significant improvement in the quality of life with clinical pathologic evidence of protection of normal brain tissue. So what they're saying is that it's tolerated, even though you may be very uncomfortable when you're doing it. It's tolerated by patients. It has a moderate increase in survival with glioblastoma patients. And it actually protects the normal tissue from radiation damage, which I think is pretty interesting. So the next publication, let me see, how far are we away from being at the end of this? Why don't we take a break here? It's been an hour and 7 minutes of me droning on about 2-deoxyglucose, melatonin, and fenbendazole. Actually, now that I'm thinking about it, did I skip the fenbendazole part of it? I think I skipped the fenbendazole slide. Let's see here. It seems like 3 minutes. Well, yeah, it has seemed like 3 minutes, but I can't believe it's been an hour and 7 minutes. Let's do this. Let me, what is this? Is this fenbendazole? Okay. So let me take these two slides, cut them out of this. I'm going to put them at the end, okay, of this 2DG lecture. We will start off by covering this paper that was published in 2015 to talk about 2DG. We'll finish up our 2DG talk. I got about 7 more slides for 2DG, and then I'll hit fenbendazole and its effects on 2-deoxyglucose, or on hexokinase, excuse me. Let's see if I can see any missed comments here that I didn't get the first go around here. High dose 2DG, similar to insulin potentiation therapy. Yeah, so I don't have any experience with insulin potentiation therapy. I think that in some ways it makes a lot of sense because you're pushing the glucose levels down super low, right? But my problem with that therapy, at least on the surface, is that I don't like the idea of giving insulin. Insulin is a growth factor. It stimulates mTOR and all these other growth pathways. And therefore, I don't think that it would be fantastic to give to patients. Now, I get that it's like transient for a very specific purpose. And I think that I could be on board with it. I actually have not near or soon plans to go out to chemothermia in Turkey, but I want to meet up with them out in Turkey and see if I can't, I don't know, just learn from them out in Turkey. So they're doing insulin, potentiated chemotherapy. It's the place that Dr. Seyfried always talks about. So I would love to go out there. The elephant in the room regarding why Seyfried, et cetera, has not become popular, I believe, is compliance. It is really hard to go without food or sugar. I don't know if I agree with that, Michael. I think that I agree with that it's difficult. There's no question that it's difficult. To get your glucose ketone index down to where you want it to be, to get your glucose level where you want it to be, where you to do all the things that metabolic therapy asks of you, not only like, personal sacrifice, but also, financial sacrifice, because none of this is included in insurance. HBOT or IV vitamin C or any of the medications that are kind of repurposed are not covered by insurance, so it's out of pocket. I think the reason why it's not mainstream is because you're not able to make money off of it. If you want me to be very frank with you, no one's going to be patenting the ketogenic diet. No one's going to be patenting metformin again. No one's going to be patenting, 2DG. No one's going to be patenting Dawn, right? Like no one's going to be patenting these things. So therefore, that is, I think, the real reason why it's not, the standard of care. I don't think it's an efficacy thing. I do think that the compliance issue is big, but I mean, mainstream medicine has been able to basically convince people to be, cut, burned, and poisoned for the last 50 years, and people still show up to the centers to get their medicine, right? And I think that it's fairly barbaric and it's miserable. It will suck the life out of you. So therefore, like, I think that also can't be easy, right? To show up every week to get injected or irradiated. So I think compliance is part of it. I think if you made it more streamlined and you had services that could maybe make ketogenic meals for people, that's like a meal service. If these medications were available, if they were cheap, if they were prescribed, if the doctors knew how to use them, if there were protocols built, I think you could make it as easy as the standard of care in terms of, almost as easy as the standard of care than regular medicine. It's just that I think that the real reason is they can't patent and make money off of it. I think that's my cynical reason why I believe it's not standard of care. Yes, caloric restriction is able to increase longevity. Yes, it is. I believe that. So, okay. Well, I think we've gone an hour and 11 minutes at this point. I kind of lost track of time. I didn't realize we were going this far. I knew it was going to be a long one just because I had a lot of information about 2DG. I wish I had more clinical information for you all. Unfortunately, it just doesn't exist, and it should. And I'm hoping that, it can exist. At the same time, I'm not going to get too bent out of shape. I don't think it has to be 2DG as our saving grace here. I think there's multiple things that block hexokinase, as we've seen, and can have a positive effect on this process and kind of help from the glucose side of things. So with that, I'm going to sign off, and like I said, we'll continue the 2DG discussion, as well as we will hit menbendazole and fenbendazol's effect on hexokinase, because I did think that was worth sharing. I have had several people in the comments, highlight that. I will say that on my initial, slide that has the HK inhibitors, I do have menben and fenbendazole here. So it wasn't like it wasn't there. It's just that I didn't do a specific kind of like slide about it, but it's okay. We can hit it, and we can talk about fenbendazole and its effective or its effects on the glucose side of things. We've talked about its effect on the glutamine side of things and having effects, similar to that of Dawn by blocking the glutaminase or the GLS enzyme. So if you like videos like this, please like it. Thank you for all the discussion in the comments. It helps me kind of like circle back to different concepts, and also it motivates me. I like interacting with you guys in the live chat, but also, after everything's all said and done. And if you're not a subscriber, please consider subscribing. If you have anybody in your life that that could utilize this information, please share it with them. I'm happy to get the information out to them if I could help them somehow. And until next time.